Good evening. Welcome, everyone. We appreciate you joining us this evening for our monthly mastery webinar, where we will demonstrate live cadaverically, a SpeedMTP, triplanar MTP fusion featuring the newly released targeting guide, our great release instrument, and a few other new innovations. If you haven't joined one of our webinars before, you'll notice that upon joining, you're automatically placed on mute. However, we really encourage and enjoy for these to be interactive. So at any point, please feel free to type in any questions or comments in the panel to the right of your screen. We'll be monitoring those and answering them as we go throughout. And if we don't hit on any, we'll have some time at the end for any residual or additional questions and comments. And now on to the main event. Joined with me tonight is our esteemed faculty, Dr. Mark Easley out of Duke and Durham, North Carolina, and Dr. Bob Sandrock out of Fernandina Beach and Duke University as well. Good evening, gentlemen. Thank you for being here.
Great to be here. Thanks, Lauren.
Thank you.
And I will turn it over to you, Dr. Easley, to take us through these introductory slides before we jump into our demo.
Yeah, I'm just sorry for the technical issue. Can I advance them or will you advance them?
I'll advance them for you.
Good. So just to be clear, there certainly is a uniform way that this is to be taught. And there are certain technique tips that are consistent, but there are some opinions in here too. So you'll hear opinions from me and from Bob. So what we'd like to do is just, there are many systems out there. Why would you use a SpeedMTP system? And what is it exactly? And then hopefully you'll get a lot out of Bob, who's an excellent surgeon, teaching you with a but a cadaver demonstration. Some of the complaints with this, and maybe some of you or many of you have experienced it, I certainly have, that often implants that are used, like dorsal plating, can be bulky. They sometimes are contoured in a way that would promote actually a malpositioning and potential malunion. And what we really want is to have a dynamic compression. In other words, not just initial compression, but that compression can be continued to stabilize the construct. And then it's something you can see around. So it's a little easier to see that a fusion is, or that the arthrodesis is progressing toward fusion. And we'd like you to be able to have your patients weight bear early. And that it doesn't matter if it's hallux valgus with a deformity or just more traditional hallux rigidus, that they're really universally applied. And just there's a lot of feedback. We didn't just pull this out of thin air, really went to talk to surgeons about what their needs were, what some of their practices were, some of the things that they really felt were most important. We try to assemble all of those and combine them into this system. And it's a surgical technique, and it's a philosophy here. It's not just simply implants and have at it. We're going to teach you some things about how to use it. But you're familiar most likely with the speed plate technology. They're also fast pitch screws. So if you used anything within the portfolio of Treace products, you're familiar with those. And these have the same features. So this is a speed plate that's been then used with the same technology work at the first MTP joint. And it works with rapid insertion. It stays low profile. And then it has that dynamic compression that all speed plates do. And it's actually relatively strong. You'll see that there's a supplemental screw fixation that can be bicortical. And then you combine it with a crossing screw, which we recommend. 1.3 millimeters thick. So compare that to other devices or implants you may use. It's quite thin. There really has this infinity feature to it at the end. So there's no prominence at the end of the plate. And even on the sides, there's some reduced profile. So it really is not, if you put it in properly, this will be right up against the bone and not have any prominence. And then you also have the screw, like I mentioned, the screw. So it's not just the legs on the speed plate, but you also have obliquely placed screws that are fast pitch technology that can be bicortical if you choose to give it even more stability across each side of the joint. Pretty compact system. There are a few other tools that Bob will show you as well. So it comes in a kit, As far as the crossing screw, you have a 26 millimeter, a 30, and a 34 millimeter. And there's a targeting guide that you see over there on the left, and Bob will show you the features that using a targeting guide, you'll know exactly which length screw to choose. Speed plate you're familiar with, so it'll have that tower with a cap. You can release it and give it more stability with dynamic compression. All comes contained within a nice kit. And there are two other products too, really things that we've just found they were important to use. And so they were developed amazing. The Treace team just goes and creates these for us. And we just say, what if we needed this? And all of a sudden we have them. So one is this great release. You may be familiar with a McGlamry type device. Well, that works, but in the kit, you can also have or available to you as the surgery is a great release. So you'll find, Bob will show this too, how easy it is to get a full comprehensive release, particularly if you're doing deformity correction. And then this feather rasp, which is one of my favorite tools that I've used. The plate, you really can't contour the SpeedMTP. So you want to get the toe provisional fixation where you want it, and then you put the guide on. If it doesn't quite fit the way you need it to, this rasp will allow you to just feather down the bone so the plate will fit absolutely perfect profile on the position that you've chosen to be the final correction and alignment. Again, key steps, familiar with these, joint prep. We're going to show you how to use a reamer system that's available to you. And that allows you to have cup and cone configuration, which allows for subtle adjustments. Once you get your initial reduction, you can just make subtle adjustments and maintain full contact. Then there's a drill guide, which I really like, because the drill guide itself will tell you exactly how the SpeedMTP plate is going to sit. So if the drill guide sits perfectly, you've feathered that down, that's how your plate's going to sit. And you can see through the holes where the legs are for the implant. And that way you know exactly if there's interference from any provisional fixation. And then you can see the targeting guide there as the next step. And that gives you an idea of exactly where the crossing screw will be, so you don't have any interference with that. And it has a way, it shows that they're 26, 30, 34, which size screw you need to choose based on lines that are there you can see fluoroscopically. And then as far as inserting the implant, it's speed plate technology. So Bob will go through that, and you're familiar with that. And then you can lock it on either side before you actually activate it. And releasing the cap there, it just is what you're familiar with already. We'll stop for one moment before Bob gets started. Question is, how is this more stable than a locking plate? Yeah, so that's a good question. Locking plate will be a static device. This too is a locking plate in that the screws that you put in will lock into the plate, SpeedMTP, and then you can have the same body-cortical fixation. The difference is this has a dynamic component to it, right? And so if you then have the construct where you want it, if you don't do it absolutely perfectly with your locking plate technology and you don't have perfect bone apposition, there's nothing more you can do. You could actually create a slight gap where it would be more difficult for the healing to occur. What this does, it has the same locking plate features because you have locking screws on each side. Then you pull the cap off, the towers then allow the activation to occur. And that way you have a locking plate type of technology along with continued compression. It's not going to change the alignment because you have a crossing screw, but it adds further compression across the construct in a continuous manner. So that's the difference. One more question. I'm sorry, I'm just getting these. Can this be used for revision surgery? Removal of a BioPro implant, can it be used if bone graft is needed? Yes, it can. And like many things, you know, this is the first featured example of this. So we've got this ready for you for primary applications. If there's a bone defect, this comes in a size 40 and 45. So there's a larger version of this, which gives you more span. Treace is also offering graft material, so structural graft that can be placed in order to make up any defect you have in the bone. Yes, it can be used now. we don't say you have to necessarily use the graft that we have, but there are grafting opportunities or grafts available from Treace. And yes, you can use it as you have a larger version of this as well. All right, Bob. I'll try to ask you for questions throughout, but why don't you talk the group through this?
Well, I think that most of our audience is probably pretty familiar with the standard approach, and we'll just get right to it. And we're just going to get through and show you the reaming system and show you how that works. You know, I think you'll be able to visualize everything pretty well. I make my incision just right adjacent to the EHL tendon. I'm gonna make it pretty generous for this demonstration so that we can see everything really well. And it's going to be full thickness. The first interesting thing we'll get to see is going to be that that grate release, which is very exciting. I used it in the lab last week and was very excited. I hear I've got them delivered to my rep today. So do we have a forceps? I'm excited I get to use them straight away. And I think these are going out across the country as of today. So we should be real excited about these. If you've used things like the speed release and the tritomes and the lapitomes, you're probably going to like this instrument. The reliable sharpness as it comes out of the sterile packaging, the way it was designed for a fit in your hand, and the depth of which something can be used. You know, I don't know if most people appreciate that, but I'll tell you that there were thoughts that went into those instruments, like the speed release is 40 millimeters long for a very specific reason. So we know how far we can plunge that device, as well as the same with the tritome for where it's intended to be used. So I'm just
Bob,
skeleton. Yeah.
I'm going to stop you for just a moment. So Kevin Kang is saying that this is for Lauren. Can't see. It says the webcam is hidden. Now, for me, I can see it just fine. I don't know if anybody else is having that problem. Do you have any suggestions for Kevin on what he can do so he can see?
Hey, Kevin, if you're on your cell phone, just turn the phone 90 degrees. Thanks, Dr. Easley.
Kevin might be afraid of blood. He might have his eyes closed. All right, so we're going to get started. You know, the standard instrumentation for me here would be a McGlamry, right? And I inevitably always get McGlamrys that look like more like doorstops than look like a sharp instrument. They're never sharp. That makes them dangerous. They're bulky. The curvature isn't quite made right. It was a great advancement when it came out, but we took that design, tried to incorporate the good of a McGlamry and improve upon it. So sharper edges and a little bit more of a radius there. The handle was made ergonomically like our other instruments that fit in your hand, give you good grip all around. And this thing is just real sweet to put underneath the MTP joint. And with just, and you can't see my hand here, but I'm going to just use 2 fingers and show you how little pressure it takes to just do that release. And it is amazing how well this does. Controlled fashion, fits right around the head. Don't feel like I'm plunging or having to force things. So you're really getting those sesamoids separated away from the metatarsal, which is the key. That's what we want to do. Now I will take it and flip it around as well and start working on the phalanx carefully if I need to. It's just the same I would do with a knife, but now I've already got this instrument in my hand. I'm gonna work on the the MTP joint of the phalanx and just get right underneath that lip there. It's hard to see for what I'm doing. Turn it to the side here. I'm getting underneath the lip of the proximal phalanx and just releasing underneath the FHL and not getting the FHL. And because it's a much larger in my hand, I have a much more control of it. And you can see I'm holding it more like a fork or a utensil, as in it just gives you much more control. It really gives me this nice, really easily opened up exposure without having to struggle. And I find that this is when I'm teaching new surgeons, this seems to be one of the hardest things, is that people try to do it through very limited skeletonization, and you don't want that if you want to have the mobility. These are hallux rigidus. You're doing this because there's some sort of arthritis. It might be a bunion, but you have some arthritis, which means the sesamoids are stuck down, and we got to get rid of that.
All right, so
now we'll-
Bob,
Yeah.
Bob, a question comes in. Alan wants to know, is there an indication to remove the fibular sesamoid? Say you had hallux valgus and you're trying to get some more intermetatarsal type release, or arthritic like you're describing. When would you take out a fibular sesamoid, if ever?
If it's truly ankylosed to the metatarsal and I cannot get it released with the grape release or a McGlamry, then I would consider excising it and removing it. I went through a period of time where I thought I should remove them all, and I did for a while with these, and I didn't find it to be all that much more useful, and I was just chasing the sesamoid around for 15 minutes in surgery. So I stopped doing it routinely and just went to doing it as needed. There are some of our colleagues who do this routinely, and I wouldn't say there's anything wrong with it. It will help you move the metatarsal lateral with time, which is what we're trying to do. We're trying to take it out of that varus position and fuse this straight so that as they weight bear, we know we'll get that IM angle to close. So I cannulated the metatarsal down the center. We now have sizes to choose from.
And Bob, one other question came in from Bryce Long here. Could you just, before you go on to the reaming, before we forget, can you move those reamers out of the way and just hold up the McGlamry next to the grape release? And the question is, like, what size is it? Are there different scoop sizes? How is the scoop compared to that of the McGlamry that most people are used to?
So first off, I would say the blade is significantly less thick. I don't know if you can see that. I'll try to rotate slightly.
No, you can see that. It's good.
And a McGlamry, which is the one closer to the foot, is thicker. When I try to come up to the end here, this is a very, very sharp end on my, oops, sorry.
Yeah, there you go.
End. It's got a slight bit of a geometry, more squared off, so it gets you almost that tritome-like blade where you have the three distinct edges. McGlamry is rounded. You would think that would be more efficient. However, it doesn't cut as well. And then when it goes to be sharpened, this just gets back to a thicker and thicker piece of metal that acts more like a wedge than it does act like as a cutting device. And so the scoop has been slightly changed. It's a little bit more of a rounded scoop. We had actually done multiple different radius here. We actually went much more aggressive. Found it was difficult to pass under the head if we had too much radius. So we found a little nice average here that was just slightly more than an average McGlamry. I think the McGlamry that I normally used was a 19 millimeter McGlamry. So that was essentially what we based this on as far as width. Is I think it was a 19 millimeter McGlamry is what we based it on. I don't know if that's the actual width, but that's somewhere similar. You can see the widths are pretty close.
Look up the
Perfect.
size.
Thanks.
All right, so I'm cannulated. Almost just start zipping through the reaming here. One trick that a lot of people like to do is they'll like to pull the reamers out and just size them on before they pick and choose. This is a pretty small foot here, so I'm envisioning this is going to be a small. So you can put it on before you actually articulate it with the drill if you wish.
And just so you know, they come in 18, 21, and 23. Those are your sizes.
Important thing is when you're working on cadavers, keep your mouth shut while you're reaming. There's a tendency for people to want to do this. It doesn't help you any, one, and you're more likely to break something. Just go end on. And a bouncing technique helps me keep it from binding down and burning the bone. I feel like it does better. Just go till we see the subchondral bone and most of the cartilage gone. If anything else needs to be driven away, we can do it with the drill or a curette at the end. Yeah, so the reamers are part of the kit you get when you do an MTP fusion with Treace. You will have the reamer options available to you. And then I'll match this up in a moment to the other side. Get the pin driver. So I'll remove my pin and put it on the other side. I have a nice open release here, so I think we should be pretty good. Abhishek just yell at me when I'm not in the view.
So Bob, tell me this. So you just did that pretty simply. Are there any tricks to putting that pin in? Because the reason I ask is that if you simulate weight bearing, do you have to pay attention to how you position the IP joint so that it really represents where the toe is going to end up when you have your final fixation in place, or is it not that?
I do try to get it to where I think it's going to be. Now I'm only in the proximal phalanx at the moment. I'll ream here. Before I drive it out, I will actually hold my thumb over the IP joint, and I'm kind of feeling the dorsal cortices of the proximal and distal phalanx under my thumb, and I want that to be a 0 angle essentially. And I definitely don't want it plantar flex and giving me a false sense of plantar positioning, because the key is we want the tuft to touch but not be hyperplantar flex. We definitely don't want it dorsiflexed. Those are not tolerated. So my thumb is over the top of the joint and it's feeling both the dorsal cortices. I'm hoping to feel that they're the same. I will check this, however. I will not rely on that alone. I will check a simulated weight bearing when I get it positioned.
And then
so right now,
before you read that, one other quick question too, just this is personal, like maybe a personal problem of mine. So you have hallux valgus interphalangeus, or you have this strange wear pattern that often happens where you get a much more lateral wear. Do you do anything to compensate for that, or do you just ream it? How do you align that when you have that interphalangeus and you're trying to correct that as well?
Well, for me personally, I probably rely on overcompensation through the MTP joint to some degree, but I will try to angulate the pinning when I'm, and I'll show you that when I'm getting there to try to accommodate that. This foot does not have much interphalangeus, so maybe I won't be able to demonstrate it well, but I do use the MTP joint to help align that for me. That's my habit.
Okay.
I got you a little bit of a side view here. You're going to see the reamer work, but you see I'm not really pulling that hard, and the MTP joint's open all because of that great release. Now I'm doing my cup side, and again, balancing technique is very, very important to prevent yourself from plunging or prevent yourself from also burning the bone and creating heat, kills bone cells.
All right. While you're doing that, a couple more questions. One of them actually I think is very good because I wonder about this too. I do this occasionally. So first is, do you ever mismatch reamer sizes? Is that a problem? If do you think you should not do that? Or are there ever times you feel like you might have to go with a different size on one side than the other?
Technically, the radius of curvature are matched size to size, and there's a very slight difference from diameter of reamer, and so I try my very best to match them up. I think I have many times and feel like I can get away with them being unmatched one size, but I would caution you that it was designed to be matched, so I do what I can. I feel like I can usually match it. I don't usually feel like it's a problem to get them to be matched. How about you, Mark? What do you do?
Yeah, it does happen occasionally where it just seems like it's going to be a perfect match, but the metatarsal head, at least the way I have it prepared, trying to save bone, will be a little bit bigger, and I'll use a smaller size on the phalanx. I've not seen it be a big problem. Sometimes I have to manually do a little bit of extra work, but I really try to maintain the contour, but I've not seen it be a problem if you downsize one going distally. The other question is, would you ever hand ream this, Bob? Because it's probably happened to you, although you're a great surgeon, or maybe in the hands of your trainees. Have you ever exploded a proximal phalanx and get a little gun shy? And is there an indication to ever hand ream this, or what are your tricks so you don't ever have to think about?
Yeah, for sure. I mean, it was actually asked of me by the crew here today if I was going to hand ream it because it's a cadaver. They were worried about soft bone, and of course, I beat my chest and said, well, it doesn't happen to me. And but it does. I've had it happen, and it can make you gun shy. I think the biggest trick I do is if you saw run the reamer on a relatively high speed. Don't try to use it, you know, on really slow. You're getting a lot of force when it's really slow, more likely to grab and bite. That's my trick. And then I'm always bouncing, and that's true for drilling too. I don't leave it and just push and plow. I'm bouncing on and off of that subchondral bone to loosen it up, get the bone debris a chance to flute out, and I feel like that has saved me probably from doing this fairly with any frequency. So we're at the stage where I've put the pin out distally. I used my thumb on the top of the cortices, and I'm retracting it back. This is a double-ended pin that you have a choice of. I like an axial wire. Not everybody does an axial wire. Some people like to do this freehand and do crossing wires. It's your choice. I've found the axial wire the easiest for me to position, but it's up to you how you like to do it. We'll have plenty of different types of pins in the kit for you. And of course, we're going to check both clinically and radiographically. I like this to be, sorry, I'm jumping you around here, but I like it to be very straight in all my directions. I'm not sure if I'm completely reduced or not. I'm going to check on x-ray. I'm going to check a simulated weight-bearing scenario. I like my heel to be on the flat surface. I like the foot to be on a flat surface, but I don't want the pin on the flat surface. So you can see my pin is actually not touching the surface here. And if you hold the foot here a little bit, or take that through, Lauren. And then I'm going to check. And for my trick, I like to see that, one, I can pass underneath the proximal phalanx body. Right here, there's a natural curvature, and then the tuft should be touching. The tuft should have resistance, but not prevent me from passing a flat instrument such as a freer, the backside of a number 4 knife handle, the backside of an Adson forcip, something like that should be able to do it. Now remember that IP joint is technically at the present time pinned. I see a little hump here, and I'm not sure if that's, you know, planarized, or we're going to check under x-ray both views. And if I like it, then I can take these bumps down with the next instrument.
And James LaPaula just wanted to say that he will retrograde the phalanx pin, one side out, ream, then re-enter the pin in the metatarsal in the desired corrected position. And usually all of the deformities that you would normally encounter will correct well and allow for a proper positioning or setting of dorsiflexion and rotational position. So just a technique tip added. Thank you. One other thing, Bob, and I want you to go over the images there, but Mark Ray wanted to know, this is more down the road, but maybe you can think about it so we don't lose this question. Definitely he's had them fuse, but over time, suddenly the IP joint of the hallux has a valgus that's created that wasn't there at the time of the surgery or even preoperatively. Just in other words, it fuses at the MTP joint, but then the IP joint of the distal phalanx will drift into some valgus. Have you had that happen? And if so, do you understand why?
Well, I think that I do understand why. I believe that is probably related to the sesamoids being released. So the sesamoids are tethered in most of these hallux valgus cases, you know, to the lateral side. They're not just straight lateral, they're rotated around the frontal plane. And if they stay in that position and continue to contract over time, or atrophy over there and contract the FHB, then you're going to get a pull on the proximal phalanx, and the FHL might bind up in there as well. I don't tend to see it, and I think it might be that my release is very, very deliberate and good. Now the great release makes that very, very possible for me. I also, you know, I'm looking at those sesamoids. I want them to be as well as I can get them underneath. I can't always get them 100% underneath at this stage, but I do know that I have it released. I can repin this. I can pull this pin back and put some more varus into the MTP joint. But to me, this is not a bad position. I'm going to be fine with this in my hands. You know, if I needed to have this straighter, I could pull this back and pin it. Do you have any issue with this? If I go more varus, it's going to look like Mr. Spock's hand. So I'm not going to do that. You okay with that, Mark?
Yeah, I mean, we'll go ahead to a question that this just came in, I think is applicable here, but we'll go ahead and answer. I was going to save it to see what you do. So the question is, like, do you have any tips for I think it fits with this, reducing the IM angle. So before you put the provisional fixation or while you're putting the provisional fixation in, do you squeeze 1 in 5? Do you use, like, would you use a positioner? What would you do to address the IM angle at this stage?
The number, I'm pushing a little bit on the met head here. You can see if that IM angle will close down. You know, it does depend on flexibility of that TMT joint. I believe this one's relatively stiff because there's slight MTA here. This is a relatively stiff foot. It's not going to reduce much. I try to get the sesamoid as underneath as I possibly can. That's another trick. I can put the positioner on if I really feel like it to do that. So it does depend on the patient goals. If you look at this foot with my finger just pushing on it, I think that's going to come together nicely. I'm just barely pushing on the met head there, and it's going to reduce that down a little bit. And I think it will do that over time, especially if those sesamoids get underneath. And I believe it is, because we know we had it loose, and I can feel in there. I can feel that my sesamoid is actually below the met head, and I know it's not tethered because I can feel a groove there that was created by the great release.
Yeah, and you asked me, I tend to put the toe a little bit straighter. Like you said, I don't want to have a peace sign or Mr. Spock kind of situation. But I do find that, and we know that the IM angle will correct to some degree, provided it's not arthritic or has some Romash joint or some type of block to it. So I'd probably tend to make a little bit straighter. We know that over time it can straighten a little bit more, but I like the position you have. I would probably make it even a little bit straighter and allow the IM angle then to come in. It's for another time, but we could do a double arthrodesis if we really got into a snag where the IM angle stayed wide, even though we aligned the toe properly at the MTP joint.
Well, for the sake of time, we're going to move on so I can show you the other advancement that we've had coming out today. Being shipped to your reps today is the feather rasp. So
can you, before you do that, can you show the foot like from a sagittal or from a lateral plane so we can see we don't really see the prominence that you're going to address? And I had mentioned earlier that I would put the guide on to see what bone I would need to feather away, but in this case, it clearly shows that you already have something where you wouldn't be able to put the guide on at all right now. So good, yeah, that helps a lot because now we can see the step off that you need to address.
All right, so this is the feather rasp. And you can see it's basically a saw blade that has been bent up. And on the undersurface of that bend are teeth that look like a cheese grater. Yeah. And I used this the other day. I've been using it in the lab for a while now. This is a very nice ergonomically positioned. So if I can show you my hand holding the trigger, you can see that allows me to have a very good position. So I will not be struggling to get at the right angle. Today I did an MTP chelectomy on an auto-fused MTP joint. And I was like, dang, I wish I had that feather rasp. It would have been a lot easier. So we're going to just get to work here.
Bob, how much pressure are you applying with that? Do you have to push really forcefully?
Barely touching, really. Barely touching. And there's a big osteophyte off the medial side that really has soft tissue on it. I'm gonna just grab that with this so we can rasp that too. It would probably work there without grabbing that soft tissue, but I'm just going to make it a little easier on myself here.
And just to be clear, yeah, go ahead and finish that. Yeah, just to be clear, maybe Lauren can comment or Bob probably knows. Does this come peel packed? So it's not just something for the.
Today, as of today, they're sterilely packed.
Yeah, and so it's not a device just for this. When
Sorry,
Bob
I keep drowning you out. I'm having too much fun.
when Bob doesn't want to hear me.
It's very addicting. You get going and you're like, oh, I can polish that a little bit.
Yeah, so, but just to be clear, it's not a device strictly for the SpeedMTP. It's for any procedure you do. It could be even in the other indications, other parts of the foot.
Absolutely.
Ankle.
Just about anywhere, really. Like all of our principles with Treace, we'd like to have 2 points of fixation once we're happy with our position. So I'm going to go ahead and pin, and I'm going to choose to go from the lateral, distal lateral to proximal medial with a second smooth pin. This is just temporary. And the reason why I'm going that direction is I'm probably going to place the interfrag screw from distal lateral to proximal medial.
All right, Bob, you just made all those beautiful reamings. Question is, could you use that as bone graft to fill in little voids, or would you prefer to go to the fast graft, or what would you do?
Well, I definitely would have irrigated after I did my initial prep, and I would have left any bone I created with the feather rasp there. I do indeed still use a fast grafter on all my arthrodeses. I started studying that and looking at it and seeing when it was noted to be helpful, and the literature was pretty clear that it's helpful in the midfoot. And I thought it doesn't seem to make any sense to not treat the MTP the same way. So I went ahead and started doing autograft at the MTP. Very, very happy. I would, there's no obvious study that says that that's necessary at the MTP. There are many at the midfoot and a TMT. I will say this though, anecdotally, as you know, Mark, I just got my own weight-bearing CT scanner, and I'm seeing very early healing with all of my constructs. And this is a change from the exact same CT scanner I had at my last job at WVU, where I was a couple of generations ago on Treace products, and they weren't healing at the same speed. So this is anecdotal information right now, but I will tell you that I am very pleased. So I'm not changing. I'm going to bone graft them, and I'm going to be using speed plates because I believe that those technologies have helped me a lot.
Got it. Another question from Garrett. He wants to know, will there be a straight feather rasp in the future? Thinks it may be better for the TMT joint. What do you think about that, Bob? I know we played around with that as an option as well.
Yeah, I will tell you that put it in your hands. You probably won't worry about the straight one once you have this one. It doesn't look intuitive to you until you put it in your hands, but I will tell you it's much more intuitive than a straight one. Will there, I would never say never, right? I mean, we always are looking for things to do. So we might be making a straight one, but I will say put this one in your hands first to see. So we've got a small foot, and we've got now a relatively flat landing spot. We will see how well I created that. This is the drill guide. You can see that there are 2 screw pods, one on the distal and one on the proximal, that are addition to your plates tines. These can be placed lateral or they can be placed medial. It's really your choice. I believe probably most people place them medial because they're more naturally open over here and more room to work. I will tell you that I tend to put them wherever my hand is working. So I tend to use this in the direction that my hand is easily positioned. So I am going to be in the right-handed position here on this right foot. So I'm going to put, and I'm working from the end of the foot here. And another thing is to note, if we can get this square to the camera the other way here, is that you'll see that little triangular notch in the bottom, in the middle of the span. Lauren's going to point at it with a pin here. These mark the joint, and you'll see that I am actually proximal to the joint right now, and I need to be actually a little distal to the joint, because the joint is not what you're looking at. The joint is actually a couple millimeters deep into the phalanx. That's something to remember from a technique standpoint. When you're lining this up, that's the center of the plate. I like to put the center of the plate right directly over the joint. The joint is going to be just a millimeter or two distal to the visible joint from the top because of the cup and cone. So I'm gonna put my thumb on there, I'm gonna hold it, and I'm gonna temporarily pin it in place. These are called hornet tacks. They're gonna go into these pods over here. They're threaded. So once you engage these, don't forget to use reverse to get them off. And I'm gonna double check the drill guide here and make sure I don't have the EHL underneath. This is a relatively small foot, so we have the EHL a little bit in jeopardy. Apologize if I'm off camera here. And this is, like I said, a slightly small foot, so I'm going to check on X-ray and see what we have to work with. Yeah, this one's a little bit too distal, but if you all noticed and picked up on it when we were starting, that proximal phalanx already started very, very short. So in this case, I don't like it. I'm gonna move it back. So we're gonna adjust it proximal. So my standard position has to be adjusted proximal.
So say that one more time about the hornet tacks. I think it's just really important. What do you have to do when you take it out?
Reverse.
Yeah, I mean, I think that's really important, because if you like your plate position or your guide position, which dictates where the plate's going to go, and you shear one of those hornet tacks off, it burns your opportunity to put the screw in, because that's where the screw is going to be. Doesn't mean you can't still move it a little, recover, but ideally you wouldn't let that happen. So be careful in not shearing these off. And how do I know?
My
Exactly.
famous words that every resident that ever worked with me knows. How do I know? I've done it. All right, let's see if I made a better position. There we go.
All right, so I'm starting to see that your provisional fixation may interfere with some of those drill holes. I mean, it's nice you can see right down them. You'll know exactly where the legs or the tines for the SpeedMTP go. When you see that, what are you going to do? You'll put a crossing screw in. You'll probably do that next, is my guess. But
Yeah.
how good are those hornet tacks? I mean, if you had to take a provisional pin out, do they hold it pretty well? Do you lose your reduction if you just
Yeah,
rely
I think this counts as one fixation. This will be another, and then I'm gonna pull the axial wire, which is going to be in the way. So I'm gonna go ahead and pull the axial wire, and then we're gonna be ready to put our temporary fixation in. So we're still always maintaining 2 points of fixation. So axial wire is out of the way, and now we can get ready to place the interfragmentary screw, and it's done through the guidance of this device. It's a right foot labeled. It's going to go on the distal pods. It's designed to go from distal lateral to proximal medial.
What if you didn't like doing that? What if you like putting the screw the other way, like coming from proximal to distal? Can you do that too?
You'd have to use the opposite, but you can. There you go. That's the left-sided labeled.
Perfect. Okay, good. Thanks.
And then we have this sled that goes in there. It's going to accept a 1-1 wire. The 1-1 wire is going through the bottom part, and this is going to go through here.
All right, so one question is, if you're using these hornet tacks, which pretty much lock the plate into the bone, isn't that going to limit your ability to compress? Is that a problem?
Well, this is only temporary fixation for the guide. This is only the guide. The implant's going to come in the native holes. There won't be any hornet tacks in at that point.
But is it going to limit you as you put your crossing screw, your screw outside of the plate? Is it going to limit that ability?
That's a great question, and we've debated this. The benefit of doing the crossing screw now is that it will limit any gapping that could potentially happen with the compression from the speed plate. So that's one option, that one benefit. Is it limiting? Maybe so. Do you have the discretion to do it how you want to do it? Yeah, you do. Some people put the screw in at the end as a static plantar placement of the screw. Or I tend to have followed the engineer's advice who say, if I have it in now, I'm more likely to prevent any excessive dorsiflexion or plantar flexion, although it was designed in such a way that we should not get that. But it's always a caution we're trying to avoid. We want good spherical compression around. You're trying to compress a sphere. It's almost impossible. So, I think it's a relatively limited screw, and I think you can put it in and then still get the benefit of the speed plate.
Yeah, and it's your choice how you want to configure the two surfaces, but you have perfectly congruent reamers, and so your job is to get the position right, and then you have a perfectly congruent position where you can get full contact and then provisionally pin it there. So you have that, and so even if you have these two Hornet tacks there, the screw will go across and tighten that a bit more, and then the SpeedMTP at the end will squeeze that a bit more. And you really, you shouldn't leave a big gap and try to compress through that. I agree. The initial provisional fixation should get good contact, and then you're just stabilizing that.
What you're seeing here is the drill sleeve coming in from distal medial, excuse me. And now we have three measurements. We have the tip of the screw, the blade, and we have the next two markings that will mark the length of your screws for you. So if you assume, or you can confirm that your blade is down against the bone, then you can tell how long you are. And we have this 34, 30, and 34, 30, and 26.
Yep.
Oh, geez.
Well, it looks like you could get away with a 26 versus a 30.
Okay. And then is that measured, because Treace has a pretty cool depth gauge too that countersinks for you as well, and you measure off of that. So if you're using this targeting guide and your blade or the end of it on the other side from where you were just pointing up on the phalanx, if that's totally flush, it is going to be accurate based on that. Is that correct?
Yes.
Okay.
You've thrown us a curveball. We do not have that pulled up. But yes, there is an available depth guide as well, that if you wanted to measure.
Yeah. No, I just wanted to make sure that that's what you get. So it is important that you get it down to bone. Remember, it's a partially threaded screw. So if you go long with it thinking you're going to get more threads or so, and it doesn't matter to stick out, that's probably okay. But it's a partially threaded screw. So if you go too far and countersink it a bit, the threads on the other side will be actually penetrating through the bone, and you won't get that fixation in the cortical bone on the metatarsal head laterally.
So, Mark, I believe you and I both make a small incision and enter this percutaneously. That's the way I prefer to do it. We have a couple of our colleagues who I won't name names, Bill DeCarbo, who's afraid to use a knife. And so he doesn't make the extra incision. He pulls the skin down. I personally don't like doing that because I feel like there's a chance, even though you have it pretty rigidly fixed, that you could displace something. So I personally just like to make the poke hole.
Yeah, I mean, you're locked in with the Hornet tacks and you have one extra V rotational pin, but I agree with you that there is a chance that you could create a little bit of pronation there that's not there, and then you'll wonder where that came from. That's it. And then you also are tugging on the skin pretty aggressively. The skin's completely relaxed here. Once Bob slides the guide out and shows you the pin there, you can actually pull the skin back and look inside, know exactly that your screw where it's going to be. So it's not as though you're blinded from it. You'll be able to see within the wound, but keep all the tension off the skin.
I personally drive that pin all the way into the second, just so it won't come out while I'm drilling. That's just me. That's how I do it. I've already measured off of the sled that was in there. Here's the countersink you were mentioning before, Mark.
Yeah, so if you really wanted to, you could put the
measuring
pin.
device.
Yeah, you could put the pin not driving it all the way through, just put it right where it needs to be fluoroscopically, or you can even look inside the wound and see it, and then you can just double check your depth with that if you really needed to.
And you could either do this first or you could drill first. It's easier to drill first, but it was in my hand. Do we have a drill?
No, didn't call it.
What diameter screw is this?
3.5 millimeter screw.
Got it. And if you, since Treace has some MIS offerings now and has beveled screws, would you ever consider using a beveled screw here, or are you pretty much, you have to use this if you're using the SpeedMTP
No,
system?
not, if you like the beveled screw, it works. We have it available as well. And we have a variety of links in that screw. And I drove that into the second metatarsal. That's why it didn't come out. Little trick there. You could also put a hemostat over here if you needed, or you can just let it come out. It's up to you, but that's how
Yeah,
I do it.
I drop a hemostat over there, so that's another way I agree with that. That's good. And then here's what I do is I just take the retractor and just peek inside the wound so I can see exactly where that head is sitting against the cortex on the phalanx. Can you show us right down the third hole from distal, just so you can see that there's no interference, that you're completely free for the leg of the SpeedMTP?
Right there.
Just externally rotate a little bit more, and then plantar flex a little. Not quite seeing it, but it looks like, yeah, there you go. Yeah, so you're going to be free. So it's just a nice way to see that there's going to be no interference. You don't have to worry about the legs of the SpeedMTP hitting that crossing screw.
Right there, right to the edge. Probably can go in one more full turn and it'll be perfect.
What does it look like when you peek inside the skin right there, like not being on the outside there, but you actually look inside the skin there, just where the screw is, so you can see inside the incision? Are you down pretty flush? Because I try not to countersink it all the way. I want to make sure I have some cortical bite on those threads.
It's very hard to see in there, but I can see it's just like maybe 1.5 threads are out.
Perfect.
All right, so that should be it. Pull the pin. And we have now a screw, a wire, and a guide. So we have 3 points of fixation. Nothing's interfering underneath our x-ray, so we're just now going to drill these holes. And I can pull my Hornet tacks on reverse.
Just one quick question. It's great, everything's good. You put the crossing screw in now. Say you didn't have that provisional wire in. would you feel comfortable right now putting the SpeedMTP in with only the crossing screw, or do you usually prefer to have one extra point of fixation just in case?
My habit with all speed plate constructs is to use 2 points of fixation at all times, because you know it's designed to fit with force. It's designed to maybe even be tapped in with a mallet, and so I don't want to displace anything. And so I have always had a habit of using all my speed plate constructs with 2 points of fixation at the time of insertion. In the Lapiplasty construct, that's the third wire that's in there at that time. You know, and I remove one if I've hit it in some fashion.
Yeah, tell me, how does the, James Lapola has a question too, we'll get that in just a second. How does the SpeedMTP come? Does it come with a cap already on it, or does it come without the cap on? When do you actually activate it like that, or just actually put the cap on? When does that happen?
It comes as like this right here with the Hornet tack holes already pre-aligned, and then you have your posts that'll go, the silver posts that'll go into the cap. Here's the cap, which is a reusable instrument, which will be in the instrument tray. And so to assemble it, it's just like the other speed plates. You'll line the caps up with the cap side, and we'll put the activating rods into the rails, and then this will pre-align the rails on the Hornet tack holes. These turn into screw diameters. You can see we're going to drill those and make them into Hornet tacks, into fast pitch screws. So
Great.
you align these tubes up with where you had your Hornet tacks, which in my case were lateral, right? So don't forget that. So you're going to line up on all 4 holes, and I like to push in to about 80 to 100% seating. This one seats a little easier than the regular speed plates because you're working at an end of the foot. It's a little bit more difficult to control everything, so we made it fit a little bit easier. A couple of love taps just for extra measure, and you leave the cap in place while you go to your next step, which is drilling for your fast pitch screws.
And real quick, just before you go, just James Lapola had a question for the crossing screw. Is that one, like he says that with the headless ones, he's able to do it without, well, just basically weakening the cortex with the drill, and then they're self-tapping and self-drilling. Is that the same for these screws, the screw you just used, or do you have to drill it every time?
Well, pretty much all screws today have a bite on the front leading edge that you could call them self-drilling, self-tapping. I'm a precision doctor. I don't like to force things unless it had an absolute point on it and was not cannulated. I probably is just going to use the guide wire, and I'm going to go ahead and step through and drill it. But that's me. Now the leading edge on the beveled screw is even more aggressive and designed for that, what you just described.
Got it. Okay.
Drill them in and out, and then now you have a laser line here that if you wanted to try to watch it go through the cortex, you could also measure these and decide what sizes. So if you want to go bicortical, I'm not a bicortical person. I like to go just like I did my biplanar plates here. So I do not like bicortical. I think, Mark, that's opposite of you. I think you like bicortical here. So to me, I'm always going to pick the relative distance. So I'm going to pick like a 14 and an 18 or a 14 and a 20, whatever we have right now. And then, so Mark, I know you are a little bit more precise, so maybe you would use those laser lines and try to pick them, or use an x-ray to see, right?
Yeah, I do. And it just adds 2 millimeters to what you just said. So I actually do the same thing you said, but just a little bit longer. And I like to catch that cortex. I usually can feel that before the locking head engages the SpeedMTP plate.
We'll put our distal one in first. In this case, it's a 14. Again, like I said, it's standard for me. I use 14 and 20. 14 and 18, yeah.
Do you find that when you do this, and you gave it some love taps, you got it to seat, you had feather rasp it so it should sit nicely. Do you find when you put these in it, like you do when you use the traditional Treace plates, that this sucks the plate down to the bone even more?
I do. I feel like it even pulls it down even further. So, oops, I popped out of my screw there. There it goes.
And I see you have not activated it yet. You
No.
leave it.
I just did it accidentally.
did it.
Yeah,
Yeah.
I did it accidentally right when I turned the last turn, but yeah, it's just a matter of.
Yep. And then show that feature just in case people don't know that the end of that cap is actually your screwdriver, right, for the towers.
It popped off accidentally. I probably would have pulled this pin before I did that, but I hit it with my hand and popped it off. So it doesn't really matter. That's a smooth wire, so probably not a big effect.
Yeah.
And you see the joint came together even more, and it fits perfectly. So this is a very small foot. I would have guessed that this is a size 6 foot. That's a small or standard implant, which is what I use on a size of a foot like this. And then I use the large implant on all males. I use the large implant on actually most people that are over a size 8 or so, but females, my first default. Now, the nice thing is you have both drill sleeves. You can look and see before you open, because the drill sleeves are in the instrument tray. So you can check and see why your fit is. So you can see I did not get into that IP joint. And you can see that the screw, the one screw you'd be very happy to see is bicortical. I actually think both of them might be, Mark. You're welcome.
Yeah, it looks good. Very nice.
And, you know, I personally, where's my lid? I mean, to me, this is exactly the way I want it. With my feather rasping, I don't think that I end up with any gap in that x-ray there. But on the clinical view, you'll be able to see here the simulated weight bearing again. And this is exactly how I want it, where I have just a gap underneath the normal portion of the proximal phalanx, but nothing under the tuft. And it just has that nice straight line down the inclination. And here's a top-down view of the implant itself. Very side view, very low profile, 1.3 millimeters thick. The skin easily closes over top here. It becomes the lowest profile, I believe, that's available, at least equivalent to the lowest profile. And with that infinity edge, it's even less. So no touch on the skin. You can see that it's wanting to just close over real easily.
So that's, oh, before you do the wedges, just a question about that construct. Can you show the construct one more time? Yeah, that's fine. You can do that. Yeah. So the question that Shashank had a while back, I'm going to circle back to it. What is more important in this SpeedMTP system? And maybe you can extrapolate it to any speed plate system. Is it the pullout strength that you're after, or axial loading of the fixation? What's most important here? What are the features this brings to the table?
Well, I think they go hand in hand, right? I mean, I think the dynamization that's built into the plate increases the pullout strength. And then it's also that dynamization that gets you the intimate fit of the bones and promotes stability at the fusion site, which promotes healing. So to me, it's the best of both worlds, being titanium as opposed to nitinol. Nitinol, which is extremely elastic, requires much more linear length to get the same amount of Newton force compression. So that's why you see when nitinol is not in bone or it's been pulled out through bone, it's overly compressed or over dynamized, right? So in this case, this will only go back to the pre-existing bend that was there. The technique is driven in such a way that that's all the bend you need. So it will not over compress. And that also allows it to work just like our regular plates did, in the sense that they'll flex and move with bone, just like the length of that metatarsal. These plates have been proven time and time again over 120,000 implants that they're designed to work with the flexibility of the bones as they function in a weight-bearing situation. So you get this added dynamization, which increases the pull-out strength, but it actually is the more compression that I like to think about that makes me feel better. But they go hand in hand. The one helps the other.
Got it. Okay, so can you show the foot one more time? The like the specimen. This is a question I have, and then we'll get into a couple more questions that have come in. I mean, you said it's a really low profile plate. That's great, and it has really smooth edges, infinity edges. But we both know that there's really nothing but this little tiny thin layer of periosteum over the phalanx. How do you actually get the distal part of the plate covered with a deeper layer? Is it possible, or what's the tissue you use to cover it? It's just that little wimpy, little flimsy periosteum that really doesn't cover the plate. It's hard to close. What do you do?
Well, I'm going to try to get a zero vicryl closure to this deeper tissue here that once was probably some of the bursa and capsule that was there. And I'll get that closed probably about 2/3 of the plate length. I'll get down here and it'll peter out, and all I have is this little gristly tissue here. But I'll do a 2-0 closure in the subcuticular tissues and the subcutaneous tissues to get that closed together. I'm not going to see plate. That's for sure. And I'll be underneath or over top of the EHL, whichever way I have to do it. If I have something under the EHL, it's the most ideal. I don't always have something I can grab. Right there's some decent tissue I can grab underneath the EHL. So that I'll do 0 as far as I can go, then 2-0, and then I do a running monocryl as my last layer on the outside. I don't do it as a subcuticular. I do it as a running baseball stitch. Everybody always says, "Oh, you're going to make bad scars." You can't see my scars any more than anyone else's. And that 4-0 monocryl, you can't. It closes really nicely. I don't use steri strips, but I change my bandages the day after surgery in my office, and I change my bandages weekly until I'm happy. And that might be 1 week for an average patient. It might be every week for 2 or 3 weeks for a patient that worries me. And that's all my incisions. They're all treated the same.
Yeah, and here's the big question of the day, right? So anybody I know, you are more anxious to get either it's a ductoplasty, a lapoplasty, or this procedure. You want to get that patient in a shoe as quickly as possible. What is your post-operative protocol and your weight-bearing protocol?
All of the family of lapoplasty family surgeries, which includes a ducto, MTP, nano now, the lappy, the doubles, the quads, they all go weight bearing the day after surgery, every one of them. Now, here's the reality. I tell people for 2 weeks, this means bedroom to bathroom, couch to kitchen, and curb to door. I don't want you walking further than that, but I want you walking that every hour. You got to get up and walk across the room. You walk across the room, you sit down, you ice and elevate, toes above the nose, and ice goes on. For 2 weeks, that's my protocol. In a MTP, hold your breath, it's a post-op shoe. It's not a boot for me. And it always has been. So that's not new to Treace. I've always used a post-op shoe for my MTPs. I didn't know I was doing anything crazy. Now the midfoot, I use the boot. But I will bring them out of this boot, out of this post-op shoe at around 4 weeks if they're doing very, very well and they're a reasonable patient. But I will throw out one caveat. I am in constant contact with my patients. I don't have 3 or 4 week gaps. I see them every week or every other week. I'm on telemedicine with them every week. They're in constant contact with me so I can coach them through. I don't trust them, but I coach them, and I spend out a little bit of extra time to do that. But because I treat everybody the same on the same protocols, it's uniformly easy for me to do. So I don't want you to say, oh, you can just give these orders and let them go. I don't trust them. I still have to see them and coach them, but I am more aggressive because I do make myself more available to them.
Got it. And then this patient, I mean, in the post-op shoe, they can put all the weight they want underneath the ball of the foot, the sesamoid. You just probably don't want them to roll all the way up onto the toe. Is that fair to say? Or
yeah, I mean, I wouldn't want them tippy-toeing, but I will say if they're in a post-op shoe or a boot, there's really almost no way to overly, I shouldn't say that. It's mechanically not created to create an advantage to get on the toe, right? So you can't really do it. I also don't think heel weight bearing does anything. I think you can tell people to heel weight bear. I also don't think it does anything because you're pulling on the EHL and the anterior tib while you're heel weight bearing. So it's just pulling on the construct in a different way. So I don't think it helps. I just tell people to walk naturally, slower stride, shorter distances, shorter stride length, and slow them down. But with that, and I have them walking right from the beginning, I don't think there's quite as much angst or anticipation to get going on it because they are walking right away. So that's how I've pushed the weight bearing. I think our hardware has done tremendous for us, and it didn't start with Treace. Treace definitely moved it along with the speed plate technology, but we've had excellent hardware since we've had locking technology. And now that we have plates and screws that are mimicking the strength of bone, I think that is also part of how this works relatively well. So walking is part of it. If you don't walk, you get more swollen. If you don't walk, you lose balance, and you get atrophy, and you just extend the recovery and make it more risky. That's my opinion. Now, I don't know if I'm doing it right, but I haven't had any significant levels of non-unions or hardware breakages or anything like that. We've done this since for 10 years now, and I've been doing MTPs with less robust fixation in a post-op shoe for 25 years. So.
Yeah, no, it's good. We got to wrap it up here pretty soon. We've got a good group still here. There was a question earlier about revision surgery, and I think you were going to show us some examples of structural grafts. What are some of the options that would be available to those watching today? And
yeah, these are available now. Structural allograft. Pull these out here. See, they'll match this card, essentially these shapes, and you're able to order these up, and they will come available for you to make bulk allografts for revision situations. Also standard reconstructions like Cottons and Evans. If you like the allograft, this is what you're going to have a choice of. These soak up body fluid very, very well. So if you wanted to choose to mix this with bone marrow or anything else, that would be a really nice thing. Or if you want to take your fast grafter and mix it in with that, I think it would be a good idea. These are cancellous grafts, human allograft.
And so what does the team have to tell their rep in preparation for that? If there's a chance this needs to be used, to just ask for the allografts and they're available now, or how does it work? Anything special?
Yeah, no, reps can order it in the same standard approach that they would order any of our product. It ships directly to the facility, not to the rep, so it'll ship to the facility. We also have trials of each of these options that come in a non-sterile tray that would ship directly to the rep for them to bring in for the case, but the wedges themselves go directly from the facility, and like I said, order as they would any of our other products.
And then if you're doing an MTP, we're talking about SpeedMTP here, do you ask for MTP wedges, or do all the wedges show up?
All of them show up. So it's one tray or one kit with all of them.
Got it. Okay, understood. Okay, that's great. We are toward the end of the call. I don't see any other questions right now, so I'm going to ask both of you. First, Bob, if you have your take-home message, and then Lauren, anything you would like to share with the group. And thank you for your great organization for this evening's call.
Well, my take-home message, since we focused on MTP joint, is this: it's not just an arthritis surgery. MTP surgery is part of the algorithm for all of the modern bunion surgeries as well. This case in particular we just did had slight metatarsus adductus, and this would not be an unusual situation if I had a patient who had slight metatarsus adductus, but I did not want to do a full 3-2-1 reconstruction. And MTP fusion to correct the hallux valgus is a great option. It's a speedy recovery, and it is a relatively easy surgery on the patient. Relatively easier than a midfoot reconstruction. So don't forget that that's your options. If you look at the algorithm slides that we've been showing in our webinars and our Bunion Masters, that's really the way I think and what I sit and I go through it with my patients, and I have those and I hand those out to the patients. Say, here's your algorithm. This is our choices. This is what each one of these would entail. And it usually helps make the decision for them. Don't be afraid of this speed plate, as far as we've been using it now for months, and we're in hundreds and hundreds and hundreds of cases. This performs well, easy to do. I think generally the feedback is it works really well, really fast. People generally like it. Patients seem to recover well with it. I haven't had a hardware complaint yet with it either. So we'll see how it goes, but it seems to be the next generation of MTP fixation.
A new era, if you will.
Yeah, I tell you, I love it. It's just, I work with trainees, and every one of them has said, it's only been around for a few months, but everyone says that is, I really like that technique, and they're used to a lot of different ways of doing this. So they're pretty excited about how easy it is. And I think it's worth everybody giving it a shot. I've really enjoyed using it too. Lauren, you've done a great job. Could you finish this off for us, maybe with some any message you'd like to send to the group listening?
Yeah, thank you. Thanks so much, Dr. Easley. Excellent job moderating. Dr. Sandrock, thank you very much for this demonstration. Appreciate everything you guys do for us. I know there's been a lot of really great questions throughout. I'll give a plug for something that we do on a very regular basis, is our peer-to-peers that are offered. So if there are any questions that you have coming out of this that you have unanswered, or you want to speak to one of our faculty about SpeedMTP or wedges or the greater Treace portfolio, reach out to your rep, reach out to the medical education team, and we can facilitate those. I know how much you guys enjoy doing them as well. And for any other questions, like I said, do not hesitate to reach out to the team. We are available at your disposal. And I'll leave you with, really excited to hear everyone that was on the call tonight feedback on their first SpeedMTP cases. Thanks, Dr. Easley. Have a great night, everyone.
Great job. Have a good night.